Now let's talk about the next delusion, and very interesting delusion, delusion of ill health or hypochondriacal delusion. So again, these are related with some bodily symptoms, some ill health symptoms. So let's discuss what are these delusions. Again, they can take the form of primary or secondary delusions, and they can be seen in various conditions such as depression, schizophrenia, can occur in delusional disorder, can occur even in abnormal personality development. Now let's try to understand when they occur in depression. In fact, they very characteristically they may occur in patients with depression. When we talk about abnormal personality development, again they may occur in the background of some health concerns. Many times we see that patient having abnormal personality development has some concerns about their health, and eventually they may develop these delusions. Now, when we see them in schizophrenia, again, as we discussed, they are characteristically seen in schizophrenia. Schneider suggested that depressive delusions are result of uncovering of patients' basic worries. So the basic worries about health which the person have, subsequently they may get transformed into these delusions in depression. In fact, very interestingly, again, this is very important point which we are discussing. We know Kurt Schneider gave first rank symptoms in schizophrenia. He also considered that locating experience of depression as a sensation in a bodily organ is equivalent to a first rank symptom of depressive psychosis. So again, that may be asked, which is one of the symptoms of as a first rank symptom of depressive psychosis according to Schneider, when the person is able to locate his depressive experience as a sensation in the body organ. So again, these may be considered according to Schneider as first rank symptom of depressive psychosis. Again, when we look at these delusions of ill health, again we'll discuss what are these various types. When we see them in depression, again they may range from something like patient may say that there is something there. So patient may just have these vague beliefs. So patient may not be able to pinpoint what is exactly wrong, but will say that I'm sure that there is something abnormal there in the body. While some patients may be very clear about their beliefs, and they may be very specific and may say that they are having some incurable disease, for example TB or tumor or infections like HIV, syphilis. So they may be very specific at times. Also, we see that in depression, it may also involve spouse or children. Many times patient claims that the children, they are infected, and they have inherited the disease, and also to get them out of the misery, that may even lead to homicide. So many times patient may be seen killing them so that they can be out of their misery. Also, at times in postpartum depression, the patient may claim that the child, the infant, has some disorder such as some learning disability. So again, such claims may also be made by patients having these delusions. When we see it in schizophrenia, it may be a result of the depressive mood, or it may be a result of any somatic hallucination. So many times patient has some somatic hallucination in the body and subsequently develops this delusion of ill health or hypochondriacal delusion, or there may be a sense of subjective change in the body which subsequently leads to this delusion. Now, more likely, these patients give a persecutory rather than a nihilistic explanation. So many times they give that somebody wants to harm me. So it is more of a persecutory explanation to these delusions. Now, in schizophrenia, when patients have these delusions of ill health, it is seen that in early stages, these are a result of depression and may develop as mistaken explanation of some general psychological and physical inefficiency. So usually in the acute stages, this may be the cause leading to these delusions, while in chronic states, usually it results because of somatic hallucinations. So again, very important to see, sometimes patient may be having underlying somatic hallucinations also associated with these delusions, and especially in the chronic state. Now also, let's discuss in abnormal personality development. Many times it is seen that insecure, body conscious person, they develop overvalued ideas of ill health, that they may develop that something is wrong, or I'm having predominant cough. These may be because of some serious illness. So such type of overvalued ideas may occur, and slowly we see that there is an increase in intensity, and subsequently the person may develop these delusions. And many times these delusions basically occur after an operation. So person having such abnormal personality development, having overvalued ideas, subsequently let us say had an operation or had a drug reaction, and eventually the person may develop these full formed delusions of ill health or hypochondriacal delusion. Now let's talk about what are the important forms of these delusions. Now Monroe, he basically described delusional disorder as an encapsulated monodelusional disorder with several subtypes. So he said that in delusional disorder there is an encapsulated delusion. We'll talk about encapsulation in the end. So basically only one sphere of the person's life is affected by delusion, and rest other things the person may be doing normally. So there may be various subtypes, such as patient may have erotomania, grandiosity, persecutory delusion, and he described the somatic type of delusion as monosymptomatic hypochondriacal psychosis. Again, this may be asked, who gave this term monosymptomatic? Monosymptomatic means patient is having only delusion. Hypochondriacal psychosis, so these basically delusion related with ill health or hypochondriacal delusion. And he gave three main groups under this monosymptomatic hypochondriacal psychosis. So what are the three delusions which are described under delusion of ill health or hypochondriacal delusion? One is infestational delusions, second is delusion of ugliness or misshapeness, and third is delusion of body odor or halitosis. So let's discuss these one by one. First, as the name suggests, infestational delusion or delusions of infestation, as if the body is being infested by some insects. So this is delusion of infestation. Again, has been described by Hopkinson, Rayleigh. Also, it is known as Ekbom syndrome. Again, very important. Ekbom gave this term Ekbom syndrome. So this is another term for delusion of infestation. Here the patient believes that he is infested with small but macroscopic organisms. So there are small but macroscopic organisms in the body. So this is a false belief. Again, please understand, sometimes becomes difficult to differentiate it from tactile hallucination. Tactile hallucination, patient will report of experiencing sensation. Here the patient will say, I know that there are some insect or some organism. Patient is not able to experience, but it is at the thought level. So it is a false belief. Now, this may occur in various conditions. This may occur in affective psychosis. It may occur in schizophrenia, usually in paranoid schizophrenia. Again, it can occur in delusional disorder. It can also occur in organic states with tactile hallucinations. So again, sometimes patient may have both. So again, one has to differentiate when the person has tactile hallucination, there will be a component of sensation. Then even in delirium tremens, often we see patient may be having such delusion. Cocaine addiction, again very important. Cocaine addiction, we know in cocaine patient may be having what is known as cocaine bugs or magnum bugs. So tactile hallucinations, along with this, even these delusions may also be present in the patient. So patient may also have this in various organic state like brain disease, cerebrovascular disease, even in senile dementia, disorder of thalamus. Again, these conditions, it may be present. Now, characteristically, when we see these delusions, they may occur in older than 50 years. Of course, they can occur in young also, but characteristically, they may occur in older age. And these patients have always had a particular concern for their person cleanliness. Many times we see that there is a particular concern. So there may be some abnormal personality development in these individuals. Also, there have been 3 stages which have been described for the development of delusion of infestation. First is there is some abnormal cutaneous sensation. Many times when it starts, patient reports of some kind of abnormal cutaneous sensation. Then illusions may develop. Many times patient may, on the skin, on the body, there may be some, there may be some lesion, there may be some rash, and the person may think that there are insects. So illusion may occur, and eventually full form delusion of infestation gradually then develops. So these are 3 stages sometimes can occur in delusion of infestation. Also, overvalued ideas and delusion like ideas of infestation sometimes occur in personality disorders of anancastic or paranoid type with no psychotic illness. So sometimes overvalued ideas can also occur. So this was delusion of infestation. Let's talk about the second delusion under delusion of ill health or hypochondriacal delusion, delusion of ugliness or misshapeness, also known as dysmorphic delusion. As the name suggests, dys means something is abnormal, morphic is morphology, dysmorphic. So patient believes or has delusion with facial or bodily experience. So patient is convinced that their nose is too big or is too small, or their face is twisted, or there is disfigured acne on their body. So such type of delusions related with the facial or bodily appearance may occur in the patient. Again, characteristically, it may occur as delusional disorder, and that is known as delusional dysmorphophobia. So again, it's a delusional disorder when patient usually have only this delusion. Also, one should be able to differentiate this from a very similar condition. So very close differential diagnosis of this is body dysmorphic disorder. Body dysmorphic disorder now is considered both in DSM and ICD, in DSM-5, ICD-11 under obsessive compulsive and related disorder. So in body dysmorphic disorder, if you see, again the name will tell you body dys means something abnormal in the morphology. So here the patient also has a similar thought, but it is more of a preoccupation. It is more of a preoccupation. So again, one should be able to differentiate it from delusion. So in delusional dysmorphophobia, the person has a very strong fixed belief. No matter what the person, you give evidence, the person will not get convinced. While in body dysmorphic disorder, it is more held with the preoccupation. So the fixity is not as high as in delusion. So again, one should know that yes, there are some differential diagnosis of this. Then last is delusion of body odor or halitosis, also sometimes referred as olfactory reference syndrome. Again, important. This term, although in literature we have used with the delusion of body odor or halitosis, in ICD-11, this term is used, more with a preoccupation. So this has been in fact regarded in ICD-11. This term olfactory reference syndrome has been used in ICD-11 under obsessive compulsive and related disorder. There, they've used it in terms of preoccupation. But sometimes this term is also used for delusion of body odor or halitosis. So again, one should not get confused. Let's discuss when we use it in terms of a delusion. What is this? As the name suggests, delusion of body odor, halitosis or olfactory. So again, basically patient has a fixed, unaltered belief that they are smelling, that their body is emitting some foul smell, but they do not have any hallucination or any olfactory experience. So here the patient claims that their body is emitting some foul smell, but they're not able to experience it. So there is no olfactory experience related with this. So usually it is seen in a context of sensitive paranoid personality development. Many times we see that patients having these abnormal personalities may develop this delusion, and often at times they may interpret others' behavior. So they may interpret others' behavior as a finding that they are smelling offensive. For example, somebody coming in front of him, somebody takes a turn. So they may interpret this behavior as if the person was able to smell, and that is why he has gone away from me. So they sometimes may interpret other behaviors, saying that other person is able to smell that, although they are not able to smell. So it's very important to differentiate it from also differentiate it from olfactory hallucination. In olfactory hallucination, person will be able to experience that smell. Here, they are just having this thought. Now let's talk about the next delusion, which is delusional misidentification. Again, as the name suggests, there is some belief related with identity. There is some misidentification of the other person. So delusional misidentification. So there are 4 important syndromes which we'll discuss under this heading of delusional misidentification. Now it includes a number of discrete but very related syndromes. So they're put in together, and they have in common, which is known as the concept of doubles. So what are the important delusions which are under this, or important syndromes which we'll discuss? We'll discuss Capgras syndrome, we'll discuss Fregoli syndrome, then third is syndrome of intermetamorphosis, and fourth is syndrome of subjective doubles. So let's discuss these one by one. First is Capgras syndrome. Now, what is Capgras syndrome? Again, in the end, I'll also give you some tricks to remember. So I've made some tricks so that it becomes easy for us to even remember when we are writing exam, or even when Viva questions are asked. So Capgras syndrome, again, it is usually rarely seen. It's a colorful syndrome in which person believes that a person usually close related to him has been replaced by an exact double. So this is his belief. Patient believes that someone closely related to me. So who is closely related to you? Your parents, your siblings, your partner. So he says that someone who is closely related to me has been replaced by an exact double. Again, it's a belief. We'll discuss this. Now, usually the close person in this syndrome is the person has close emotional ties with, and towards whom there is a feeling of ambivalence at the time of onset. So usually when the person develops these beliefs that someone else has been replaced, that someone else usually is a person with whom he is emotionally attached to, and during the time of onset there may be ambivalence, mixed feelings, both good and bad feelings may be present for that individual. So usually it is seen. Now let's discuss this clinical scenario. So I just try to make it a bit fun so that we understand. So let us say we have a patient who is admitted, and the patient's wife, his actual wife, comes to meet him. So when the wife comes, this patient claims that I know you are looking like my wife, but you're not my wife, you are a hospital nurse. So what is this? So basically he says he accepts that physical appearance is of my wife. So there is no problem in the perception. So he claims that the close person here, in this case wife, has been replaced by exact double, that is by the nurse. So this is Capgras syndrome. So again, I've made this trick so that you can remember. Again, some mnemonics I've made so that it becomes easy for us to remember. So the name is telling you everything. Look at the name, Capgras syndrome. So here, close person replaced by a stranger. This is the belief in Capgras syndrome. Okay, so always remember this clinical scenario so that we don't get confused. Now also I'll discuss some tricks. Now, physical appearance, is it same or different? Here the person says, I know you're looking like my wife, in the case we discussed. So physical appearance is same. So the person says that there is no change in the physical appearance. So again, sometimes when we get confused how to remember, see in the clinical picture with whom the person is fighting or arguing with. So C for Capgras, remember, C for close person. So person is arguing, is fighting with the close person. Like in the case person is arguing with the wife, na, you are not my wife, you are someone else. So this is Capgras syndrome. Now physical appearance, as we discussed, is same. There is no false perception. But very interestingly, so patient says, I know you're looking exactly like the original, you're looking exactly like my wife. But very interestingly, patient usually reveals that there are some distinguishing stigmata. For example, in this case, patient may say, my wife would never stand like this. So although you're looking like my wife, but my wife would never stand like this. Or my father would never walk like this. So such distinguishing stigmata sometimes patient may say in Capgras syndrome. Now let's talk about Fregoli syndrome. Fregoli syndrome is again a delusional misidentification. It is just the opposite. It is delusional misidentification of an unfamiliar person as a familiar person, even though there is no physical resemblance. Now the person is claiming that an unfamiliar person is actually a close or a familiar person. This is Fregoli syndrome. Patient believes that various people whom he meets are rarely the same person in disguise. So patient is believing that a familiar person is coming in front of him as a stranger, as an unfamiliar person. So let me give you a clinical scenario so that it becomes clear. Let us say we have a patient, Mr. Freg. He's walking and he finds a stranger. Let's call him S1. So he has never met this stranger. When he sees this stranger, he says, I know you're looking like a stranger, but you're not a stranger. You are my wife in disguise of a stranger. What are you doing here? Go back home. So he's convinced that the wife has come in front of him as a unfamiliar person. This is Fregoli syndrome. Let us say he walks forward and he meets another stranger. Let's call him S2. Again, he has not seen this person in his life before. Again, he claims that I know you look like a stranger, but you're not a stranger. You are my wife in disguise. What are you doing here? Let's go home. Let's go home. So this is Fregoli syndrome. So again, if we see, physical appearance is same or different. He is acknowledging that physically you look like a stranger, you look like someone else. So physical appearance is different. Again, to remember, again, with whom is the patient arguing or fighting with? He is arguing, he is fighting with the stranger. Again, it is not given in books, but just a way to remember, just some tricks to remember. So in Fregoli, the person is fighting with the stranger or with an unfamiliar person. So this is Fregoli syndrome. Now next is syndrome of intermetamorphosis. Again, as the name suggests, what is intermetamorphosis? Here, patient has a delusional belief that others can undergo radical changes in both physical and psychological identity, culminating into a different person altogether. So other person can swap identities. Such is the delusional belief. So intermetamorphosis. So person believes that one person can undergo transformation into a different identity. So this is syndrome of intermetamorphosis. Again, please understand, nothing of this sort is occurring. It is only his false belief. Then last is delusions of subjective double. So as the name suggests, here the person has delusional belief in existence of physical duplicates of self. Patient believes that his doppelgangers, they exist. And these duplicates are usually, thought to have different psychological identities. So person may believe that he may have doppelgangers with different psychological identities. So this is syndrome of subjective doubles. So these are 4 important delusions under delusional misidentification. Also, since we are discussing, there is one more term which you can just remember. In reduplicative paramnesia, what happens? There is a delusional belief that identical places and events, they exist. So this is reduplicative paramnesia. When we talk about these delusional misidentification, so Burson basically, he reviewed a series of cases and he found that patients having these delusions, 55% were having schizophrenia. So it can be seen in schizophrenia. In fact, one of the conditions which has these syndrome, then it can be seen in bipolar disorder, even in organic disorder. Again, we'll discuss. Even in organic disorders such as dementia, acquired brain injury, epilepsy, even in cerebrovascular accidents, patient can have these delusion. In fact, there is a growing evidence that organic disorders may have these delusional identification. In fact, these delusional identification, 25 to 40% of them may be seen in these organic disorders such as dementia. And very interestingly, as we also discussed when we talked about neurocognitive disorder, one of the dementia associated with the Capgras syndrome, if you remember, Capgras syndrome, many times patient comes with Capgras syndrome and the person may be having underlying Lewy body dementia. Of course, it can be seen in other dementias such as Alzheimer's disease also, but sometimes Lewy body dementia patient presents to us with the Capgras syndrome. So it can be seen. Then in acquired brain injury, epilepsy, cerebrovascular accidents, they may occur. And also neurological findings have also been done. They show that there may be right hemisphere abnormalities, especially the frontal and the temporal regions. And interestingly, these areas are basically implicated in face recognition, or you can say face processing and recognition. So again, there may be some neurobiological basis, and we are seeing areas which usually are associated with face processing, with recognition, are basically involved in these delusions. So these are some of the important content of delusions which one should be aware of.